Today, we will be showcasing a presentation on COPD and CAD, which are the two sides of one coin, and a case-based presentation on acute pulmonary embolism by Dr. Bhavin. Dr. Bhavin is an associate professor from Oakland University, William Beaumont School of Medicine. He's the Vice Chief, Division of Pulmonary and Critical Care Sleep Medicine. He's also the Associate Program Director, Pulmonary and Critical Care Fellowship, and the co-director of the respiratory course. He is a fellow of the American College of Chest Physicians and a member of the American College of Physicians. He is further the Clinical Educator Award, Oakland University, again from William Beaumont, and the Teacher of the Year 2016 from Beaumont Health System. He has been the invited faculty at national and international conferences and a part of many research presentations and peer-reviewed publications. Further to this, we also have with us Dr. Nitesh Shah, who is a senior consultant pulmonologist. He's a pioneer in Ahmedabad in the field of fibro-optic bronchoscopy. His vast experience in obstructive airway disease and interstitial lung disease and sleep medicine. He's also the vice president of Association of Chest Physicians of Gujarat. It's a great pleasure to have you here, Dr. Bhavin and Dr. Nitesh. We shall go towards the videos now.
Talk today about the COPD and the coronary artery disease. Both are more or less same or the two sides of the one coin. I think this is the best way to prevent smoking if we advertise this way. And it is true though, actually there are data to support this one. So I have this case and I would like your participation. I have this 60-year-old guy who has a shortness of breath and chest pain. He has intermittent chest pain. He has 35 pack year smoking history. His heart rate is 85, blood pressure is slightly elevated, 150 or 95. Respiratory rate is 18. The pulse ox is 90% on room air. His stress test was done. It was positive for the ischemic changes. CAD was done showing the 90% obstruction of LAD. Stenting is being considered. He was started on the medical management with the aspirin and the statins. PFT did show severe obstruction, which was compatible with COPD with 35 pack year smoking history. So I have a question for you guys. Which of the following is true regarding our patient? A, patient should be started on home oxygen. B, heart disease in the patient with a COPD has no impact on outcome. Metaprolol can cause bronchospasm and further reduction of the FEV1. Metaprolol can be considered for the CAD and hypertension. Only how many people voted? Everybody voted for B. I think the correct answer is actually D. Metaprolol can be considered, and let me show you one by one all the options which is correct and why. So the first concern is that patient should be started on home oxygen. I think none of you guys actually selected, which is very nice. As we know that the people who have a PaO2 between less than 55 or SpO2 less than 88 are the people who will require home oxygen. And in a NET trial or the National Emphysema Treatment Trial and the LOT trial, oxygen treatment trial, when the people use oxygen for more than 16 hours a day, got the benefit in mortality. Now, if the people have a PaO2 between 55 to 59 or SpO2 88 to 92, they need additional qualifier, for example, P-pulmonale or the core pulmonale or the CHF, polycythemia, then they are going to get benefit from the home oxygen therapy. Our patient did not have any of those things and his saturation was 90%. I did not give you the values of the ABG, but assuming the PaO2 is more than 6, he doesn't require home oxygen. So that option was incorrect. Second option is that the heart disease in patient with COPD has no impact on the outcome. I think a lot of you guys have chosen this one, but let me show you the data where the relationship of the COPD and the CAD comes together. For example, this was a study done several years ago, and they checked the coronary artery calcium score, which can be, it doesn't work here, I guess, looks like, which can be measured as a Augustin score. The people who have the COPD, smokers and non-smokers. You can see that the people with the COPD have a significant high level of the calciums in the coronary. And this is a graph showing that the people who have a high calcium score actually had a more mortality over the period of time. What about the CAD and COPD and MI? I think it is very well known that the patients with the COPD, they eventually die because of the MI. All of you guys probably have seen that. And the Valiant trial showed that there is a significant increase mortality in the patient who has COPD versus the people who did not have a COPD, in spite of adjusting for the smoking years, in spite of adjusting for the all other risk factors. So the COPD and the MI is more, COPD and mortality is more. In the Eclipse trial, you can see that actually every single coronary artery disease or every single heart domain, they were significantly increased in the patient who has COPD. For example, here you can see these are this pink or red bars are the COPD, these are the smokers and these are the non-smokers. So heart trouble in general, like random heart trouble, hypertension, angina, heart attack, stroke, heart failure, arrhythmias and hypertension, everything was much more compared to the people who did not have a COPD or the people who are completely normal. Again, the COPD and heart disease have a significant mortality, the people who have a COPD. So I think the COPD is actually one of the very important independent factor for the patient who have a heart failure or the mortality. Same thing happened with the people who have a COPD and heart failure alone. For example, this is a COPD as a diagnosis, not proven by the gold guidelines. So COPD and COPD with heart failure have more mortality. These are the two last graphs. COPD according to the gold guidelines, meaning by FEV1 FVC ratio was below 70, and the COPD with a gold guideline and heart failure. So the more mortality was always there, even in a subgroup of the patient who has a heart failure. Third option was that metoprolol can cause bronchospasm and further reduction of FEV1. How many of you guys believe that this is true? This is what been taught to us when we were in a medical school, by the way, right? When we used to read the Satoskar, our, the pharmacology textbook, and the contraindication. This is one of the absolute contraindication that the people with a COPD or asthma should not be given beta blocker, especially even a cardioselective beta blocker. And this is a common teaching, I guess, even in United States or anywhere I have seen. People have a strong belief that the people with a COPD should not be given a beta blocker. So let me show you the very interesting data. This was actually a meta-analysis of almost 22 studies. 11 studies has checked the effect of the metoprolol or the cardioselective beta blocker as a one dose pre and post FEV1. And another 11 studies have checked the effect of long-standing beta blocker up to 8 to 12 weeks. So the people got a PFT before beta blocker, people got a PFT after beta blocker. And what did they find in the meta-analysis? That FEV1 does not go down, very important part. There was absolutely no significant reduction in the FEV1. Patients' respiratory symptoms, they did not change. So nobody actually complained of a shortness of breath or wheezing. The effect of the beta agonists like albuterol or the salbutamol actually had no difference even if they had a placebo or the metoprolol. Same way in a subgroup analysis for the people who had an obstruction, for example, asthma or COPD, there was no difference. And same way the people who have a cardiovascular disease, there was no difference between the placebo and the beta blockers. So I think we should definitely now change our consideration that the beta blockers are contraindicated in the patient who has a COPD or the asthma. That part is completely old. I guess the best option is probably the last option. The metoprolol can be considered for the CAD and hypertension. I would like to specify this statement. I have intentionally kept here for coronary artery disease and or hypertension. And I will show you some data. For example, beta blockers, they reduce the mortality. So in this study, you can see that this one doesn't work, but you can see that the people who were on a beta blocker versus who are not on beta blockers, there was an advantage of the survival. Another study also showed that the in-hospital mortality was significantly reduced if the people were on a beta blockers. I have still one more clarification to make after I show you this data. For example, this is a meta-analysis for the people who have an acute exacerbation of COPD, coronary artery disease, heart failure, and hypertension. And you can see that the people who were on a beta blockers, their overall mortality was significantly better. Unadjusted, even adjusted mortality was slightly better. So not significantly better, but slightly better mortality. Again, these are retrospective data. So the value of the data is always little less. People who have a COPD and acute exacerbation. So here you can see that the people who have just COPD or a stable COPD, these are the people who have an acute exacerbation of COPD. Those who were on a beta blocker versus those, even in this case or this case, the both side, the people who were on a beta blocker had important reduction in the mortality. Now, I would like to highlight the statement which I highlighted before, that the patients, all these people did get a benefit if they had a coronary artery disease or a hypertension or a heart failure, meaning by the indication for the beta blockers was present. COPD itself is not an indication for the beta blocker therapy. So this is one of the study published just last month in December, is known as a block COPD trial. Based on the available data, people thought that let's give the beta blockers to the patient who has a pure COPD. So the people who were on a beta blockers for any cardiovascular indications, they were excluded in this particular study. So these are the people who only have a COPD and nothing else. This is a randomized controlled trial of the Metaprolol versus placebo, almost a year-long follow-up. The main people they were included had a moderate to severe obstruction on a PFT. Also, half of the patients were on a home oxygen therapy. Another half of the patients actually had an increased exacerbations in the previous years. So these are the patients who were high risk of the increased exacerbations. They were given metoprolol on one arm and the placebo on the other arm, and then they were followed for the exacerbation. What they found, in fact, that these people were given beta blockers, there is actually increased COPD exacerbations with beta blockers. Completely contradictory finding, which I just showed you. This trial was actually stopped early because the people, because of a safety concerns, because the beta blockers did cause more exacerbations rather than the placebo. So what I said before, that the beta blockers might have a less exacerbations or less mortality, provided they have a cardiovascular indication of beta blocker. So you should not give a beta blocker just for the sake of the giving beta blocker to the patient who do not have any cardiovascular indication. Otherwise, they are not going to get any benefit. So in conclusion, or in a summary, CAD and COPD are two sides of one coin. I think I am not surprised at all, because the common denominator is smoking. If a person has so much smoking history, which can cause COPD, probably it can cause revealed or unrevealed CAD. Second, the beta blockers are not contraindicated if they are indicated for a cardiovascular indication. So that should be one of the very important take-home message. Beta blockers can be given for CAD, CHF, and other cardiovascular concerns, and probably it will improve mortality in those subgroup of the patients. Beta blockers should not be given for the reduction of acute exacerbation of COPD or to block the COPD for the COPD itself. With that, I will say thank you very much. So we'll talk about the acute pulmonary embolism. I guess all of you guys see this disease quite commonly. What to do and what not to do, or when to do. I don't have any disclosure for this talk. So every time we see the patient of pulmonary embolism, the first most important question we ask to ourselves as well as the patient is the patient hemodynamically stable or not? If the patient is hypotensive or not. If the patient is hypotensive, meaning by the systolic blood pressure is below 90, there is no controversy. We try to thrombolize those patients. If the patient has a contraindication to thrombolysis, then we try to do a catheter-based thrombectomy or embolectomy. So I think that is a very standard of care, and we don't have any controversy or a problem with this particular scenario. The problem is with the PE without hypotension, when the patient is hemodynamically stable, so-called stable. What do we do with those people? So then we check the other things. For example, RV dysfunction. RV dysfunction can be checked either on the CAD scan, the CT scan. If the RV to LV ratio is more than 0.9, meaning by RV is dilated, or the same thing happens on the echocardiography, we can say that the patient has a RV dysfunction. And or the positive biomarkers. The two biomarkers are troponin and the BNP. So we kind of take care of those biomarkers, and based on that, we can say the patient might have a intermediate risk PE or the submassive PE, which is now the old terminology. So if the patient has RV dysfunction and or the positive biomarkers, we usually try to see the S-PASI score, also known as a pulmonary embolism severity index. The pulmonary embolism severity index, or simplified version, you can remember by mnemonic S, PEPSI instead of the PASI. which is a kind of a SpO2 pulse rate, elderly patient, pulmonary or cardiac disease, systolic blood pressure, and the infiltrative disease or a cancer. You get a 1 point for each of those things. If the patient does have a 1 point on a PASI score or more, RV dysfunction is present, these patients are known as intermediate risk PE or a submassive PE. Finally, they don't have any S-PASI score and not hypotensive. Those are considered low risk pulmonary embolism. So as I said that the most controversial part or the most problematic part is this middle group. The prevalence rate is anywhere between 50 to 60% of a submassive PE, and the mortality varies from anywhere between 3 to 10% even in the the best setup. That's why I think this particular spectrum, the one with the orange color, is the most important to understand. With that, I have a case for you. This is a 55-year-old guy who has a shortness of breath for the last 2 days. He has a 20-pack year smoking history, diagnosed to have a COPD, had a flight travel, and of course, he was diagnosed to have a saddle pulmonary embolism. You can see the pulmonary embolism. Blood pressure was 105/76, heart rate was 114, pulse ox was 91% on a 3-liter nasal cannula. RV to LV ratio was 1.5, so quite massively dilated or enlarged RV. BNP was also significantly high, 550, and troponin was also elevated with a 1.2. So if I summarize my patient, the patient has a S-PASI score of 3 based on the heart rate, COPD, and pulse ox. High intermediate risk P because the patient has a positive right ventricular dysfunction as well as the positive biomarkers. So the question for you guys, are you worried about this patient? Yes, no? We have that system working or no? How many of you guys are worried? Let's see, you have that. It doesn't display. Oh, wow. Almost 97% of you guys are worried. I guess it's right. The next question is that will you thrombolize this patient? Patient is not hypotensive, remember. So this is not our class 1 indication. Patient is hemodynamically so-called stable. Would you thrombolize this patient? If you can have a poll. Let's see how many of you are courageous enough to thrombolize. Oh, 85% of the people are saying thrombolysis. Let's see, is it a correct answer or not? And I don't think there is a correct answer or the wrong answer. But I think you guys are worried because you calculated a clinical risk associated with this particular case, which can be calculated by the BOA. There are several systems, but just one of the system is known as a BOA scoring system. Based on the troponin, you get a 2 point. Based on the RV dilatation, you get 2 points. Based on tachycardia, you get a 1 point. And the patient is hemodynamically stable, so 0 point. But total BOA scoring system is approximately 5 points. This one is translating to the risk of the death within 30 to 90 days, about 10%, which is considered to be pretty high risk for this particular type of scenarios. So even though the patient was not hemodynamically collapsed, would you thrombolize or not? That's a question. This is the largest trial so far in the history of the pulmonary embolism, known as a Patho Trial, was published in the JAMA in 2014. What they did, they randomized the 500 patient on the thrombolysis arm and the 500 patients on the heparin arm, which is our conventional or the standard traditional therapy. Everybody had intermediate risk PE and everybody had a high intermediate risk PE, meaning by RV to LV ratio was more and the biomarkers were positive. So this was a randomized controlled trial, so far the largest study. In that study, they did not find any difference in the mortality at 7 days or any difference in the mortality at 30 days between the heparin arm and between the thrombolysis arm. So there is a very controversial issue that why do we need to thrombolize? If I thrombolize this patient, ultimately, if there is no change in mortality at a week or a month, why should I thrombolize? Because this does come with a significant cost of the major bleeding. Major bleeding was absolutely much more in the thrombolysis arm, and even the stroke risk was almost 10 times more than the compared to the heparin arm. So there is a significant risk associated with the thrombolysis in the PE is quite different than the thrombolysis in the MI or a thrombolysis in the Even if you don't thrombolize, if the patient is going to survive after a week or everything is going to be okay, why do we need to take a risk? So this was a study was concluded with a negative consensus that in case of intermediate risk PE, we shouldn't thrombolize. But the Chatterjee actually did a meta-analysis after. So far, from the 1970 onwards, 1970 to 2014, all the randomized control studies who have included the intermediate risk PE were included in this trial, and they have studied almost 1,700 patients now in the meta-analysis compared to 1,000 patients in the Patho trial, and they found that if you thrombolize, there is a slight advantage on the thrombolysis arm compared to the traditional or heparin arm. Unfortunately, to save one life, we need to thrombolize 60 patients, which will come with quite a bit cost of the major bleeding and the stroke. So still this is a question that should we thrombolize these people? Even though the risk of the mortality is high, we are not probably going to get advantage. If you look at very closely, only one trial out of all these trials is not crossing the midline. This is the only positive trial which was giving a positivity to the meta-analysis as a whole. If you look at that trial, the Facilos trial, they have a very high risk type of a patient. RV to LV ratio was high, BNP was pretty high, like my patient. And in a Facilos trial, the mortality in the control arm was 17%. So mortality in a heparin arm was a 17%. That's why those people did get a benefit of thrombolysis, not the routine intermediate risk PE patient got a benefit in the Pathos trial. Point I'm trying to make here that the intermediate risk PE is a very broad category. We need to identify a subgroup of people in the intermediate risk PE who are at a very high risk of dying. If the mortality is going to reach to the 15 to 17%, those people probably might get the mortality benefit. This was another study, just a radiological study, and found that when RV to LV ratio was more than 1.5, mortality was 17%. So I think we need to find out the very, very high risk of the people for a death rather than just labeling them as an intermediate risk PE. So I think correct answer for my patient might get a benefit of thrombolysis because my patient has all these characteristics. But if I apply the pure Patho trials finding, I don't think that there is a benefit for the mortality in my patient. So there is no correct answer, right or wrong, between the thrombolysis and no thrombolysis for this intermediate risk PE. But we need to definitely or carefully monitor this patient. I guess I don't have a time to show you the second case, but as Dr. Kirby said that I have some time for a question answers, if anybody has a questions. I will not thrombolize at that point. I will definitely monitor very closely. Actually, my second case was about that. So the people who have a change in the S-PASI score after starting on a heparin. So the conventional treatment is starting the heparin. So we have to start the heparin, monitor that they are reaching to the therapeutic goal within next 6 to 12 hours. In spite of the reaching to the therapeutic goal on the heparin, if their S-PASI score is progressively increasing, for example, my patient S-PASI score was 3, after 36 hours, the S-PASI score is 5. Then I will probably thrombolize at that time, but I may not thrombolize upfront. There is no advantage overall on the down the road, so I won't thrombolize upfront for that patient.
Good evening, Dr. Patel.
Yes, Vicky.
Thank you for joining in. I'm adding the live questions over here in the private chat.
Yes, yes.
Can you please take up those questions one by one?
Yes, I have one question. Is it true that after severe COVID lungs involvement, surviving patient develops pulmonary fibrosis and end up with lifetime oxygen support? That is the question, I think.
Yes, there are also other questions. Once you are, please answer this, and I'll be adding more questions as well.
So should I answer? Should I write the answer or should I speak?
No. You just have to speak. You just have to speak the question, and then you have to speak the answer.
So the question is it true that after severe COVID lungs involvement, surviving patient develops pulmonary fibrosis and ends up with lifetime oxygen support? Uh, we have seen many COVID patients up till now. We must have seen around 800 to 1,000 COVID patients. Out of this, 100 patients were critical, and out of this, around 50 to 70% we have 50 to 70% we have ventilated. So in those patients who recover, we did not see any of the fibrosis requiring long-term oxygen support. We see the fibrotic bands and fibrotic strands, but that patient are able to manage and patient are able to recover well, and they are able to they do routine day-to-day activities also. So those who recover, those who don't recover, they are stuck on the ventilator support. They ultimately die after long-term illness. So recently we discharged one patient with 70 days of ventilator support with severe ARDS. So even in severe ARDS, those who recover, they recover completely. So another question is role of thrombolysis. Is it role of thrombolysis? Is it asked in relation to COVID, or it is asked in relation to something else?
As Dr. Patel, because the topics were related to CAD and COPD and the acute pulmonary embolism. So, in relation to that, they've asked the role of thrombolysis therapy.
So in the CAD, we all know that thrombolysis is required when there is acute ST elevation AMI. So there is no need to answer that. In the role of thrombolysis in acute pulmonary embolism, uh, in most of the cases, anticoagulation is sufficient, but it is thrombolysis is recommended in patient with massive persistent hypoxia requiring ventilator support. So in these two cases only thrombolysis is recommended. So another question is, what are the common symptoms of COPD and CAD? So the common symptoms of COPD and CAD is exertional breathlessness is the common symptom of COPD and CAD, and here you can differentiate by doing PFT and by history taking. By history taking, if patient is smoker and patient is also having associated cough, then patient is having more likely to have COPD. In patient with COD, the symptoms will be like angina. On exertion, patient will be having breathlessness. Along with it, that there will be anginal chest pain. So another question is, what are the effective methods implemented to predict the risk of coronary artery disease in COPD patients? So here the to diagnose the CAD in severe COPD patient, it is very difficult, because usually as a screening method you require to do TMT, and COPD patients are not able to do TMT. So here you can do stress echocardiography. If it is positive, then this patient might be having CAD. Is the another question is the use of beta blockers in the management of COPD is associated COPD associated CAD is preferable? Yes, you can use cardioselective beta blockers in patients with COPD and CAD, like nebivolol, etc. So clinical diagnosis of CAD in COPD, that I have already discussed. Patient will be having anginal pain along with exertional breathlessness. Can we avoid respiratory infection of coronavirus by betadine throat gargles and steam inhalation? No, you cannot avoid. It is not proven that steam inhalation and betadine gargles prevent coronavirus infection. Another question is chances of pulmonary embolism in bedridden patients taking ecosprin with statin. Taking ecosprin and statin does not prevent the development of embolism in bedridden patient, because in a venous thrombosis, antiplatelets platelet does not have any role in venous thrombosis. So giving antiplatelet does not help in preventing embolism in patients who are bedridden. So here you will have to give uh, either low molecular weight heparin or conventional heparin to prevent embolism. How long warp acetylene should be continued after PE episode? After PE episode, warp or acetylene or any nowadays newer anticoagulant are used. It has to be uh, uh, continued for 3 to 6 months, or till there is a reversibility of precipitating factor. Like if patient is bedridden, and so the anticoagulation should be continued till the patient is mobile. Thank you. Pritika, any other question?
That's all, Dr. Patel. You can please conclude.
Okay. Thank you.